Hello, my name is Omar Gibran, and today, February 1st, 2021, I will be giving you a small but vivid presentation on osteoarthritis. Let's begin. The typical patient presentation. A 63-year-old overweight woman comes to her physician complaining of a long history of bilateral knee discomfort and lower back pain. She is a nanny for her grandchildren and has a difficult time cleaning up after them. She says, "My joints are stiff in the morning and hurt the most in the evening." She was treated with an intra-articular injection of corticosteroids to her synovial cavity 6 months ago, along with instructions to consume 600 milligram calcium supplements with vitamin D 125 UI capsules at meals. The etiology of osteoarthritis is that of an idiopathic disease, meaning that it cannot be cured by the body or by medication, and in fact, osteoarthritis is a degenerative and biomechanical disease. Some theories of the degeneration of these biomechanical mechanisms include obesity, which causes stress on a patient's load-bearing joints, their age, as their joints will be wearing down naturally over time, the patient's athleticism, because the more strenuous activity a patient performs, the higher likelihood of biomechanical degeneration. If a patient suffers from trauma to their skeletal system, such as a car accident, or a fall or fracture, or even just a sprain. And last but certainly not least are endocrine deficiencies, such as hyperparathyroidism or hypothyroidism, and even just the natural menopause can all attribute heavily to the degeneration of their articular cartilage and osteocytes. Now, some background information. We may wonder, how common is osteoarthritis? Well, osteoarthritis is the most common age-related disorder of the synovial joints specifically. Osteoarthritis is so common that 5 out of 6 elderly will experience it asymptomatically across their lifetime, while 1 out of every 4 of those affected will feel the symptoms. Annually, there are over 280,000 hip replacements in the United States alone, and just over 600,000 knee replacements across the United States. So we can now see just how common osteoarthritis is. Some risk factors of developing osteoarthritis are the increasing of age, as at the age of 50, risk increases exponentially. Past biomechanical traumas or long-term mechanical stress, such as high-performance athletics, will most certainly increase the risk. Patients who suffer from congenital skeletal deformities, where the anatomy of their bones themselves will lead to the inevitable damage. Any patient who suffers from an endocrine or hematological disorder will be at an increased risk of developing osteoarthritis as well. And last, if a patient is on any medications that would stimulate the collagen catabolism, such as indomethacin and colchicine. The pathophysiology of osteoarthritis is of 7 steps. In the beginning, the articular cartilage surrounding the ends of joints loses their smooth appearance. This cartilage begins to deteriorate, becoming a yellow or brownish-gray color. As the patient moves and puts weight on their joints, this articular cartilage begins to flake off, leading to fibrillation or what looks like striations and cuts out of the cartilage. As the osteocyte matrix begins to collapse under the pressure, the subchondral bone will become sclerotic and small cysts will surely develop. Over time, these cysts will grow larger, and as pressure builds from the biomechanical stresses of everyday life, they will rupture, forcing collagen digestive enzymes and chondral fluid across the synovial cavity, tearing and degrading the articular cartilage and enabling osteophytes to manifest. These osteophytes cling to the subchondral bone and begin to change its anatomy, leading to early joint effusion or a partial loss of joint movement. The osteophytes that envelop on the subchondral bone are like tiny spurs collecting minerals over time until the patient's biomechanical stress forces them to break off into the synovial cavity. These small fragments will irritate the synovial membrane, eventually causing synovitis and accelerate the loss of joint mobility. It should be noted that the pain associated to osteoarthritis is more prevalent to the synovitis than to the damage of the articular cartilage. Hence the reason why 5 out of 6 elders will have asymptomatic osteoarthritis, but only 1 in 4 will experience the onset of painful inflammation. The final stage of osteoarthritis occurs once the joint capsule has become sclerotic. There is little to no mobility of the joint, as the joint capsule has now adhered to and fused with the underlying bone. Once succumbed, the risk of tearing the small ligaments supporting the knee is almost certain. These include the ACL, PCL, and in severe cases where so much biomechanical stress has been applied, the LCL and MCL, completing the full osteopathic cycle of mechanical knee degeneration. Here we can see a comparison between a healthy joint and one suffering from osteoarthritis. You can clearly see how the osteopathic knee is inflamed, having an enlarged synovium and capsule. Notice how the articular cartilage on the osteopathic knee is worn and flaking away. Take note how the subchondral bone of the osteopathic knee has lost its osteocyte matrix, and never forget how the space between the joints is becoming more narrow with time. We will see some more examples of this later on in the presentation. The symptoms of osteoarthritis. In the beginning of this presentation, I enlightened the case of a 63-year-old overweight woman who comes to her physician complaining of a long history of bilateral knee discomfort and lower back pain. Because the patient is over the age of 50, her risk of developing osteoarthritis is exponential. Because the patient is also overweight, the mechanical stress placed on her joints has caused the articular cartilage to wear away, and now she is experiencing the pain of fibrillation and early joint effusion. The patient is also postmenopausal, meaning osteosynthesis has already begun to decline, a surefire symptom of osteoarthritis in the present and future. She also noted that she is a nanny for her grandchildren, and caring for them causes stiffness in her joints, along with pain every evening. This stiffness and discomfort is a subtle symptom that osteoarthritis has indeed impacted her joints, but more importantly, her quality of life. We diagnose osteoarthritis in two ways. The first is for early stage osteoarthritis. The magnetic resonance imaging machine is extremely useful in identifying the early stages of the disease. This is because a magnetic resonancegram will clearly distinguish soft tissues such as cartilage defects, bone marrow lesions, and cysts, but they can also show effusions along the bone, the sensitive synovium, as well as the supporting ligaments of the joint. On the other hand, radiography allows for the detection of the more well-known characteristics of osteoarthritis, such as osteophyte formation, the narrowing of the joint space due to the lack of articular cartilage, and the hardening of that subchondral bone. It should be noted that osteoarthritis may be diagnosed without the use of an MRI or radiography, so long as the patient is within the at-risk age group and show at least one other symptom. Here we can see a clear distinguishment between the magnetic resonancegram and the radiogram. Understand that the MRI clearly shows the osteophyte formation, as well as the deterioration of articular cartilage, and expresses the collapsing osteophyte matrix. On the radiogram, we notice a clear difference between the normal joint gap and an osteopathic joint gap, whereby which we can see late-stage joint effusion. There are several treatments for osteoarthritis, and most physicians will recommend non-surgical treatments unless complete joint effusion has occurred. They include improved stability through kinesthetics and a change of diet. Orally consumed anti-inflammatory drugs are highly recommended, and even the injection of corticosteroids are common. When applicable, a physician will recommend surgery. Some surgical treatments include the knee osteotomy, a unicompartmental knee arthroplasty, and in severe cases, total joint arthroplasty, of which I shall go into the details shortly. When a patient participates in non-surgical treatment, what they are really participating in is physical therapy, stability exercises for the purposes of strengthening the muscles around the joint, loosening the stiffness of a fusion, and decreasing their body mass index to lower the amount of stress on the osteopathic joint. An increased consumption of calcium and vitamin D is almost always recommended, as it will not only decrease the rate at which osteoclasts break down the osteocytal matrix, but with combination of kinesthetics, there will be an increase in the rate of osteosynthesis. For patients suffering from synovitis, anti-inflammatory drugs are highly recommended, as they reduce the swelling and pain associated to the pathology. As a quote, quick fix, unquote, many physicians will recommend the injection of corticosteroids, as they not only modify the functions of cells who are participating in inflammation, but they prevent the proliferation of inflammation, giving many patients instantaneous relief. When applicable, a physician will recommend surgery. The first is the knee osteotomy. It is twofold, as the first kind is to remove cystic debris from the synovial cavity and to relieve the pressure from fluid built up by inflammation. A great and easy surgery for preventative early osteopathic joints. The second is an osteotomy, more invasive. Its purpose is to partially or fully reshape a part of the bone with the intention of performing a unicompartmental knee arthroplasty, or just simply a partial knee replacement. The surgery was designed to address a partial osteopathic knee before the degeneration becomes worse and the condition goes to a point where total joint arthroplasty would be the only option. Not only is this operation less invasive, but the patients recover much faster compared to the complete joint arthroplasty, which I will get into shortly. When unicompartmental knee arthroplasty is not an option, a physician will recommend a total knee joint arthroplasty. The intention of surgery is to improve the joint's movement and to correct the deformities and malalignment caused by late joint effusion. The surgery begins with a complete knee osteotomy, where both the distal femoral bone and tibial head are removed. Then a titanium upper knee component is cemented onto the distal femoral bone. A titanium rod is then inserted into the tibia and cemented into place, whereby a tibial tray and spacer are connected. A patella button is then cemented in place, and after suture, the arthroplasty is complete. This is by far the most common, as most people do not know they have severe joint effusion until their onset of osteoarthritis has developed painful symptoms. They simply have too little cartilage, and it's too late in life. And it is certainly noteworthy to remember that cartilage is avascular, meaning that there is no blood and therefore no repair. Now here on the left, you can see the difference between a healthy knee joint with picture-perfect articular cartilage and an osteopathic knee joint that has begun to degrade. Under both of these, we have a post-arthroplastic knee joint, and on the right, you can see the clear distinguishment in the radiogram between the pre-osteoplastic knee and the post-arthroplastic knee. We can see that the alignment of the joint has been straightened and that the gap between the bones has filled. We can see the femoral component, the tibial component, and even the cement used to hold all the equipment in place. That concludes my PowerPoint presentation on osteoarthritis. I hope you found this educational and entertaining. My name is Omar Jabran, and I thank you for listening.